Where it shows the left part and the right part, I think it's 401.
All right. Hopefully I printed out the correct, well, I have both case studies. So, Frederick is scheduled as a surgical technologist on a laparoscopic cholecystectomy for a patient diagnosed with cholecystitis and cholelithiasis. He is assembling supplies and preparing the OR for the case. It does say here that some of the things you probably won't be able to find in the chapter, and you might have to look in chapter 13 and 14. Of course, I guess they didn't tell you that, right?
No. No. Figured it out.
So what laboratory studies do you expect to find on the patient's chart?
The diagnostics. My paper.
So it's not asking what you're going to do for the procedure. It's
No.
Laboratory stuff. So
Right.
Blood work to see why, if there's something the liver is secreting extra or too much.
Yep.
So you'd be doing a blood test for sure.
Yeah.
There's high levels of certain hormones that cause.
Yep. So blood work. So that's laboratory studies, is blood work. So are diagnostic image studies likely to be a part of the patient's preoperative workup? If so, what kind? How will they be viewed in the OR?
So they probably did a cholangiograph, right? Before they're going to go and take it out to see if there's anything in the ducts.
So yeah,
And it's going to be up on a monitor.
Yeah, usually they're going to do chest X-ray, abdominal X-ray, cholangiographic studies. And then how are they going to look at them in the OR?
Monitor.
Yeah, and the monitor. The old way, and some of this stuff will refer back to the old ways. They used to bring them on film and put them up in the box. Yeah, the viewing box. Then it says ultrasonography might have also been done, but if you guys just got the gist of it, that's fine. Is it likely that any studies will be performed during the procedure? What kind? How might this affect the room preparation?
Maybe like a biopsy, also making sure it's in the pathology zone.
So what is one of the main things they do when they take out the gallbladder? What kind of what do they usually perform? It's just kind of routine.
Squeeze everything out.
They do a cholangiography. So a cholangiogram, basically they inject contrast to see if there's any stones in the duct. They want to make sure that nothing's in the duct, and that's pretty standard. Some surgeons are like, no, sometimes, but some surgeons every single time. So you need to prepare the room by making sure that there's enough room for X-ray to come in and take those pictures. The OR table you need to make sure that you can see the films through it. So what does it need to be?
Sterile. Radio.
What's the difference between radiopaque and radiolucent?
Radiolucent doesn't
Radio
pick up the radio tech.
Right. So you need to make sure it's radiolucent, and most OR tables are, but they have to be turned a certain way. So those are things, and you guys will learn that when you go to the OR, how they turn the bed and how they prepare for this whole surgical procedure. They always want to be ready for the just in case. So even if that surgeon doesn't usually do contrast, they're going to get ready for it anyway, just because. When you're not ready, then they want it.
And then if you have like X-ray people coming in and stuff, you want to keep an extra eye to make sure they're not contaminating the sterile field.
You do want to keep an eye on them. Most of them that are in the OR, they're used to being in the OR, and they know about the sterile field. So they're pretty careful. They're probably even more careful than a lot of people. Yeah, so they're good. They're good at it. All right, so does that make sense? Yeah. Okay, good. All right. Just kind of starting at the beginning of the chapter, history and physical exam is something that always has to be done on every single patient that comes in the OR. Of course, it's going to help the surgeon figure out what kind of problem the patient's having. And sometimes by looking at them, they can determine. Of course, they're going to gather information from the patient. But that's one of the first things that the circulating nurse is going to look for in the chart is a history and physical. Without one, they can't have surgery. And so the surgeon has to have one in their chart. It has to be signed. And then, of course, a physical exam should be performed on them. And it's going to just, what's going on, what kind of symptoms and signs are they having. And then, of course, there's a lot of different ways that they can determine what the possible problem is. So diagnostic imaging. So usually they'll use like radiography. So x-rays will be used to view internal structures. Remember that x-rays are, the energy is measured in joules. But for x-rays, it's rad, which means radiation absorbed dosage. And that's the standard unit of an absorbed dose of ionizing radiation, okay? And everything that I bring out in the chapter is probably those questions that are on that review. I'll make sure to highlight those for you.
Wait, so that again?
So all these things that I really bring out in this chapter are probably going to answer those questions on the review.
So everything on the slideshow works through.
Yeah, it does. But I'll kind of highlight things that I feel like you really need to know. So some things that radiography uses is like to have a mammogram, mammography or myelography. So in the OR, plain radiographic films from a fixed X-ray tube may be included in cystoscopy, rooms for retrograde urography, and cystography. So those are things that are in cystoscopy. Or a portable X-ray machine could be used for some of these purposes. They'll identify the location of abnormalities and foreign bodies. So if there's a bullet, they want to know where that bullet is. So they're not going to just say, there's the hole, it's in there somewhere. Unfortunately, when you get shot, the bullet doesn't just go straight. It kind of goes however it goes. Kids will swallow things sometimes, so they might need to see where that thing is. I did, let me go back here real quick. Get this little video here for a portable X-ray machine because I want you guys to kind of understand how they work. Oh yeah, put this thing on mute.
The volume on the video itself.
Yeah. So she's got film, and she's putting that behind the patient. And then, of course, they have to take that film to be, what do you call it, exposed. So that's basically portable x-ray, okay? And that's how they work, is by using those, well, film things, film changers or whatever. Come here. I'm a pain with this thing in the way sometimes. So fluoroscopy utilizes X-ray to project images of the body structures onto a monitor. Many intraoperative applications like angiography, cholangiography, retrograde urography. It aids in bone realignment and prosthesis placement. Also verification of catheter placement and lead introduction to direct instrumentation. On those portable x-rays, it requires, like I told you guys, a cassette, and it's unexposed x-ray film, and then it has to be positioned opposite of the tube. So wherever they need that x-ray, the tube will be opposite of it. So if they're doing a back or whatever, the tube's going to be up here. They don't, of course, put it on the back. The primary goal of us is to protect our field. Lateral films require the use of a portable cassette holder that can be positioned opposite of the tube. And I don't see a picture of one of those, but let me see if I can find one real quick. Let me see. Yeah, I don't think it's going to show one on this. All right. Anyway, it is, they can slide the film into it and set it on the opposite side of the patient. And usually what we do is we'll cover that with a sterile drape, and then you can bring it right up to the patient, right up to their side, because of course the patient is, they have a sterile drape and everything. We're usually in the middle of a procedure when they're doing that. So Mammography can be performed in conjunction with a needle aspiration biopsy, during which a very fine, long needle may be used to biopsy a tumor after it's located on X-ray film. All right, I'm gonna have to see if I can read this. Let's see.
Minimize your,
This here?
Yeah.
There, thank you. This might show us something. We'll check it out real quick.
This is a video of an ultrasound-guided core needle breast biopsy. The lesion is localized using ultrasound. Local anesthesia is injected in the biopsy site. To avoid unnecessary trauma to the skin, a small skin incision is made with a scalpel blade prior to the biopsy. The biopsy needle is inserted into the lesion using ultrasound guidance. Here you can see the lesion. And this is the biopsy needle. When the biopsy gun is fired, the interior shaft of the needle is fired first, immediately followed by the exterior sleeve, 22 millimeters into the tissue. The biopsy material is placed in an indentation in the interior shaft. The material is placed in formalin for pathological analysis.
So they're taking like a core sample.
So they did on that one, and that wasn't really what I was looking for. Normally what happens is, see if I can find another one.
I know.
Yeah, it was like they took it almost like a core sample, stuck it right in there.
Your doctor has recommended that you undergo a breast biopsy procedure using a hollow needle to sample a portion of a lump or thickening in the breast.
That's it.
Biopsy is a general term which simply means the removal of tissue for microscopic examination. Your doctor intends to remove tissue from the breast, not because you're necessarily ill, but because breast biopsy is a very accurate method.
I've been needle aspiration, but that's a different type.
Yeah. Anyway, it's somewhat like those biopsies, except for the difference is that when they come into the operating room, they still have that needle stuck in their breast. And that basically is pinpointing to the surgeon where they need to go to get out the biopsy tissue that they're going to take out. So the surgeon is going to get that needle that's sticking out about that long, because it's real long. He's going to cut it usually, and then he or she they'll cut around that, and then they send that with the needle still in it to pathology.
And
They
that goes
usually,
in formalin, right?
those are usually going fresh.
Oh, okay.
because they're waiting for the results to make sure they got the area that they need to get. I don't know if I shut Zoom off here.
So you know how they have like the 4D ultrasounds and stuff? Would that help better instead of like the normal gray and white pictures? Like have they tried using the 4D or is the gray and white pictures work?
Oh, yeah, the gray and white's good. Yeah.
I just didn't know like it would look really different in the 4D.
I think just mainly probably for cost. In the OR, they don't. Yeah. All right, back to this. So myelography is used to evaluate the spine for patients with neck, back, or leg pain. Myelography has the added benefit of clearly outlining bone tissue. To use myelography, they have to use a contrast medium, which is injected into the cerebral spinal fluid at the lower lumbar level. Contrast medium outlines the spinal cord and the nerve roots. And then, of course, fluoroscopy. Amplification is achieved with use of an image intensifier. So the images may be viewed during movement and projected in real time, allowing the action of joints and organs to be viewed directly. So usually when you think of fluoroscopy, you're thinking of C-arm. So they can do whatever they're doing with the C-arm in place, and the tech can basically just put their hand on it and continue to get pictures while they're doing whatever they're doing. So like if somebody comes in and they have a broken bone, they can keep moving that until they get it in place, and they'll see it as they're moving it. They'll see the bone. And like with kids, you know, sometimes they'll just set the bone back in place, and then they'll cast it, and they're good. With adults, a lot of times they're going to go ahead and put in plates and everything else. But so that's how fluoroscopy works. With the other one, with the other machine that I showed you, they have to wait to get the picture back. It's not automatic.
Okay, this
With
is.
C-arm, they've got like a screen in there, and they can see right away what's
So the
the
C-arms
image.
with the cassettes.
The
The C-arm.
C-arm is not with cassettes.
So,
It's the
No,
other one.
that's the portable. Yeah, that's
C-arm is like a live X-ray.
Yeah, it
You're not-
is.
You're not processing films, right?
right. You're not.
Just
live.
Right. They could
Monster.
save those images if requested. They could save them, but they're live, and so they use C-arm for more and more in the OR than they do portable, just because of time. Let's see, what else about this? And of course, they call it the C-arm because of the way that it's designed. It looks like a C. The image intensifier, the tube is always in opposition. So you've got the C. So basically, I mean, no matter what, wherever they've got it, you've got the intensifier on one side and then the other one on the other side, basically taking the picture. So they'll use it in conjunction with special radiographic table that allows X-rays to pass through the tabletop. And what is that referred to as?
Radiolucent.
Right, radiolucent. So they use that in cardiac cath, like I was telling you here. When they do cholangiograms in the OR, they'll use it. Urography. Let me see here. So angiography remains the reference standard for assessing the cause and severity of peripheral vascular disease. It's an invasive procedure that must be accomplished under sterile conditions. So they usually do angiography when they're doing like heart catheterization and things like that. It allows the visualization of most veins and arteries of the body following the intravenous or intra-arterial injection of a contrast medium. So some equipment that is necessary, it includes X-ray unit that can do fluoroscopic. And these, like I was saying, they can be recorded or videotaped. Also, they can make still pictures, film changers for still shots, pressure injectors, contrast media, catheter, guide wires, and needle cannula assemblies. Those are things that are needed for angiography, some of the equipment. So what is contrast?
Radio thing.
The dyes.
It is the dye, but what is it? How does it work? It's not. So when you put in contrast, when you think of that word contrast, it's not penetratable by X-ray. So it
Reflects it.
yeah, basically you can't see the area, I guess. Most of the contrast that they use is water-soluble, organic, and bound with iodine. So that could be a problem for some patients if they have an iodine allergy. So that if they do, you know, of course they're going to ask them if they know if they're allergic to iodine. If they are, they can't use this on them. Some of the names are Hypake, Cystographin, and Rhinographin. And they all have varying amounts of iodine. It says in proper dosages, they're usually quite safe, but they can give a patient too much. And if it's allowed to remain in tissue, then it can become a problem. And then, of course, like I said, if a patient's allergic to it, hopefully they're going to test them prior to any procedures with contrast before they give it to them. You probably know if you have an iodine allergy, if you have peanut allergy, allergy to fish, just some of those things. And they do inject contrast intravenously. They may use flexible atraumatic guide wires to protect the intima of a vessel. And a typical guide wire is called a J wire because of the flexible tip. And I'm going to show you guys this procedure here in just a second. The tip at the end is shaped like the letter J. It's the floppy curve at the end is useful for negotiating tortuous sclerotic vessels. There's a procedure, it's called Seldinger technique, and it allows for easy entrance into most vessels of the body. The most common artery is the femoral, the method of choice. Usually the local is the most painful part of the procedure. After that, they don't feel anything. It's the needle. So this is the wire that's typically that J wire that's got the curve on the end. This one doesn't, that they're showing. That's how they do that.
That's cool.
Yeah. There's several procedures that they use that technique for. So that one showed a cardiac catheterization type thing if they're going in to check for sclerotic arteries. They'll go in and they'll push that wire along the way. Sometimes they'll use the brachial artery, but this involves an incision and a cut down of the vessel. The term cut down refers to making an incision and dissecting through the tissue layers to expose the vessel, and then making an incision into the vessel for introduction of the catheter. So that's why the femoral route is the most popular. The term ejection fraction refers to the percentage of blood that is pumped out of a filled ventricle with each heartbeat. Normal ejection fraction is between 55 to 75%. Right heart studies are accomplished with the aid of a balloon-tipped Swan-Ganz pulmonary artery catheter attached to a transducer and monitor. Pressures are taken in the right atrium to rule out right or left ventricular failure. Hopefully, if I get a chance, I'd like to send you guys to the cardiac cath lab just so you guys can see how those work. Some hospitals that, well, they don't usually use surgical techs, so the surgeon does pretty much all of it. Kind of drives you crazy when you see it because they don't do things sterilely like we do. They try.
Or the lab does.
Surgeon doesn't. Yeah.
Surgeon doesn't?
No, so it's kind of weird seeing it like, oh, that's sterile technique? Yeah. Cholangiography, a diagnostic tool preoperatively and intraoperatively during cholecystectomy or common bile duct exploration. And then again, contrast is used. Let's see. CAT scan is the use of a specialized X-ray machine that produces pictures of the body part in slices for the evaluation by radiology. So it slices the body. One time I went to Bodies. I think I've kind of talked to you guys about that before. They have a a moving, it's basically people that donated their bodies and they cut them. So they cut them like if you were looking at them in a CAT scan into slices. They just have different, I mean, they've got several different bodies and they're of course of real people. And they just did different things with them. Like they showed all the veins and arteries and they dyed all the veins and arteries to show how many a person has. Just a lot of different stuff.
Don't they have that in Vegas?
They had it in Vegas. They had it in Albuquerque one year, so I went to it when they had it in Albuquerque. It was awesome. It really was. For some people, they'd be like, weird. But yeah, if you ever get a chance, go to one and see it. It's amazing. Most of the people that they had their bodies were Asian. Like, I can't remember where they were from. China, I think. Most of them, because I asked why the lungs look so bad, and they said because the majority of people smoke. Majority, like 90% of the people there smoke. And of course, it's so polluted over there
There's no
too.
EPA in China.
Yeah, it was bad. But very interesting to see. They showed somebody who had implants in their legs and just different things. It was really amazing. I'll have to look it up and see if it's any place. Maybe it'll come back to Albuquerque again. I hope so. So CT scan uses electromagnetic radiation to create an image from approximately 4,000 different tissue densities that are sorted into different groups. CT is better than MRI for emergencies related to the brain because it is faster and better able to detect fresh bleeding. And then there's PET scanning. It combines CT and radioisotope brain scanning. So PET scanning helps to identify how different areas of the brain function by highlighting chemical or metabolic activity. So what's the difference between MRI and CAT scan?
Yeah.
CAT scan is showing you slices.
Right,
MRI's done.
right. Then MRI uses radio waves, and so it's not radiation. So it's safer, I guess. So if you have implants, you can use MRI. I think that's what it says. Well, MRI can do, it says it can do slices
Oh,
from any direction.
I got you.
Yeah, CTs are from,
Head to toe.
yeah.
You ever done an MRI?
No,
You have to lay in a tube, like this tunnel thing, and you can't move.
for a long time, right?
Oh, MRIs?
Yeah.
They're not bad.
I think, well,
It depends on if you're
if you're twitchy,
claustrophobic.
it sucks.
Yeah, and yeah, I guess sometimes they can take quite a while. So people who have anxiety of closed spaces, they can give them something to relax them. Some people have to be put to sleep to have an MRI.
I just got to listen to a bunch of music.
Yeah, they do try to help make it comfortable.
Yeah.
MRI is good for soft tissue. So it's usually going to be used for brain disorders. If somebody has a herniated disc or something that has to do with the spinal cord, they'll do an MRI. And then the contrast used for MRI is not iodine based. Ultrasonography is high frequency sound waves are detected in to the body and reflected from the tissues to a recording device for diagnostic purposes. And frequencies of 1 to 10 million hertz are necessary for diagnostic studies. The beam that is produced is directed into the body, and variances in tissue density are reflected back to the transducer as it echoes. And those images are, those echoes create images. And it's good for checking the heart and abdominal pelvic cavity. Can be good for, useful for identifying carotid artery stenosis. It cannot be used on the lungs because it cannot pass through structures that contain air. It's ideal for the fetus because it does not use ionizing radiation. And then echocardiography provides a two-dimensional image of the heart by directing beams of ultrasonic waves from a sonar-like device through the chest wall. So it's useful for the assessment of valvular function and intraventricular blood volume during cardiac surgery and for the detection of cardiac chamber enlargement and septal defects. Doppler ultrasonography. A Doppler monitor measures blood flow that transmit the sound of moving red blood cells to the transducer. It's used in the OR to determine the patency of arterial anastomosis. You guys know what anastomosis is, right? So basically taking two things, maybe they cut part out and putting them together. So that's anastomosing, when they bring something together.
Take a slice out.
Yep. Yeah, so in the OR, and hopefully, I'm sure you guys will be able to see when they do like venous access, let me think. They do a lot of declots because of the amount of patients that they have here with kidney failure, diabetes. They have a lot of problems with their venous flow, and they get their blood clots. And so what they have to do is basically they put a catheter in there, they run it in, they blow up a balloon. It seemed like somebody showed a picture of a balloon in one of their presentations. It's deflated while they put it in, and they get it on the other side of the clot. Then they inflate it, and then they pull that clot through. So that's a declot. And when that clot comes out, and it's a clot, and you'll see it, when it comes out, boy, that thing just shoots blood. So those are sometimes bloody procedures. Yeah, they can be.
I just said that was awesome.
Oh yeah, it is. It is. I enjoy doing those.
But that's a good one.
So once they anastomose the vein, the vessel that they've had to take apart or bypass, they're going to use the Doppler to hear to make sure the flow is going through. Because sometimes they'll do that and there's still a clot someplace along the line. So they want to make sure before they send that patient out that they've got that clot and the flow is good. You guys will hear it. It just sounds like a heartbeat or like flowing. So you'll hear it in the OR when they use them. They use them pretty commonly. Isotope scanning involves intravenous injection of a radioactive isotope into the patient prior to the imaging study. So a lot of times isotope scanning is referred to as nuclear medicine. When we get to chapter 20, we're going to talk about this MIBG scan of the adrenal gland. But a collection of isotopes in a certain area can be referred to as a hot spot and may indicate the presence of a pathological condition. So a bone scan would be an example of an isotope scan. Radiation kills cells by interfering with their metabolic activity. So of course they use radiation when someone has cancer. So they want to keep it from spreading, so they basically kill it. Laboratory or pathology department, they're responsible for countless types of examinations on every type of body fluid and tissue that exists. Findings are extremely valuable in sorting out what may be normal for one patient and abnormal for another. Hematological studies. Venous and arterial blood is drawn from the patient for visual or computerized examination in the lab setting. On the table there on page 405, I know on the review, let's see. So on the review, it says know the different types of white blood cells. So really what you need to know is white blood cells, leukocytes are 5,000 to 10,000 mm's, which is what?
Millimeters, that many?
Micrometer? Anyway, know that. Lymphocytes, know T lymphocytes and B lymphocytes. So,
Know the percentages? Is that what you're saying?
see, I'll have to look at the question. I don't think you need to know the percentages. I think you just need to know the T and B. They're T and B. So on hemoglobin, know the difference between the male and the female. On the hematocrit, the percentage of hemoglobin is grams per deciliter, and then hematocrit is measured in percentages. So male's 40 to 52%, and female is 35 to 46%. See if I can find that really quick. Yeah, it says to know the normal blood gas ranges, arterial oxygen saturation. What should it be at? What are the percentage range of capacity? So it should be between 96 and 100%.
The MM cubed is cubic millimeter.
Cubic millimeters. Oh, okay, I didn't see the cube, but yeah. Okay, yeah. So with tissue specimens, you guys need to just make sure that you're really careful with them. I've seen where they've accidentally thrown a specimen in the trash and had to go dumpster diving and try to find it. I mean, because that patient came in to get that piece of tissue taken out to find out, you know, what's going on. And so that patient's gonna have to come back for another surgical procedure if we don't find it. So it's very important. As soon as you get a specimen, if the surgeon's okay with it, just get rid of it, give it to the circulator. You don't want to be responsible for it more than you need to be. Labeling, the circulator is usually going to be the one labeling it, and you need to repeat what the surgeon tells you, because a lot of times they'll say, how do you want it labeled? And the surgeon will say, oh, do this. And, you know, sometimes they don't talk very loud, so you have to repeat. So you got to be paying attention all the time. And then, of course, foreign bodies, you know, they could have legal value if it's a bullet or something. You know, it could be something that needs to be preserved. This thing goes fast. It goes way ahead. Smear and brush biopsies, they're filled with cells that can be smeared and fixed on a microscopic slide. Basically, we're just sending those things to pathology and they're doing the smears. We're not taking care of them. Aspiration biopsy is they're getting a needle and they're basically taking out fluid. So they're aspirating the fluid and then they're sending that fluid. So they might do a culture and sensitivity where they get the tube and they'll get like a long Q-tip and they'll dip it in that fluid and send that to lab. That could be an aspiration biopsy. And then incisional biopsy is the removal of a portion of the tissue mass or lesion for pathological studies. And a lot of times those are going to be sent frozen, which means they're fresh. And then the lab gets them and they cut them into slices or however they need to look at them. So when they're sending something frozen or fresh, that means the surgeon wants to know the results of it quickly while the patient's still there. If you send something in formalin, they can tell the surgeon the results of that later. So we're not waiting in the OR for the results. So anytime we send like gallbladder or the stones, they're going to usually put those in formalin, and they'll just basically they're just telling insurance that yeah, they did have stones. Those were really stones in there. Amputated limbs are going to be sent to pathology. They'll check it, they'll do cultures on it and see if there's infection in there that maybe they need to treat the patient, you know, further. There's usually something going on for them to amputate a limb. So anytime something is suspected of being infected, they're going to do a culture and sensitivity. If the patient comes in and the doctor thinks they cut into something and this nasty pus comes out, doctor most likely is going to ask for a culture and sensitivity. Okay, and what we do is the circulator usually hands us they have the tube and we twist off the top. It's sterile, and we give that top part, Q-tip part, to the surgeon. They dip it in, whatever, and then we give it back. We put it back in the tube, and that's how it's sent to pathology. So anaerobic, what happens to bacteria with anaerobic? Yeah, so a lot of times with culture and sensitivity, they're going to stick that in that tube quick so it doesn't die. Gram stain, you guys remember microbiology and staining things and the colors they turned out when they were positive and negative? What color?
Blue.
Blue is positive, pink
Pink
is
is
negative.
negative.
Right. So remember that for this. There's a question about that. Spinal tap. Cerebral spinal fluid is withdrawn, which that's what they consider tap, from the lumbar area of the spinal column for analysis. Fluid should normally be clear, and so if it's not, that already tells them there's a problem. Thoracentesis. It involves the placement of a needle into the posterior portion of the pleural space for analysis of pleural effusion. So they're going to, could include removal of fluid accumulations within the thoracic cavity. A lot of times they're going to do a CT or ultrasound on them to ensure the accurate needle placement into the pleural cavity. Then there's ECG. Right. ECG is a valuable tool for detection and evaluation of all forms of heart disease, especially myocardial infarction. It should not be the only diagnostic tool, because in certain instances it may appear normal in patients with cardiac conditions. Electrocardiography is performed by placing a number of electrodes in predetermined locations on the skin of the arms, legs, and torso, and it listens for electrical activity of the heart. The number of electrodes, they're also referred to as leads, varied according to the patient and the situation.
So then for the ECG ventricular repolarization phase, what wave cycle? That would be the cardiac cycle?
Yes. Sometimes they're going to put a 24-hour monitoring halter on the patient and have them wear that so they can monitor basically the symptoms to see, because sometimes when they come in the office they don't have any symptoms, so they'll have them wear this halter around, and that way when they're sleeping, just normal activity, they can see what's going on with the heart. It has a portable tape recorder and 1 or 2 electrocardiographic leads. And then, of course, they'll do like an ECG, an exercise test, and they call it a stress test on patients sometimes. There's lots of different kinds of stuff. EEG is display and recording of electrical activity of the brain. And it measures the changes in electric potentials. It can help diagnose seizure disorders, brain tumors, epilepsy, and other diseases, and injury to the brain. Sometimes they'll use intraoperatively when they're doing some cranial or spinal procedures. EMG is a study and recording of the electrical activity of skeletal muscle. So information about muscle contractility and innervation can be assembled. Any other questions?
Can you go back over on that, how different view can be taken? On the view?
Oh, okay. So I think if you know A and P, you know what A and P view is?
Anterior and posterior.
Right.
Yeah.
Anterior, posterior, and then also lateral. And those are more, what do they use when they do those views? What are they more typically using? That old one that I said they don't use that much anymore. Right.
A what?
The one with the, yeah, using the cassettes, right?
Cassette.
Oh, cassette. I didn't hear you. Sorry.
I know.
So the portable, right? So really with the portable, they're doing anterior, posterior, or lateral. Otherwise, they're using other things to do different views. Any other questions?
Yes. What are the questions on the test?
Those are them.
They're closer. What?
Those are them.
Oh, those are they?
Those the review, kind of.
Review.
If you know those, you'd be good.
Okay. Well, I tried. Sorry, guys.
She's always trying something. What do they use to stain tissue?
Ground stains.
What are they called?
Stem tissue.
To stain tissue.
Yeah, for
So
diagnosis.
they use alcohol and
Crystal violet.
Yes, crystal violet. So what kind of contraindications might be a problem for patients that you might want to use contrast media on?
allergy iodine.
Right, allergy to iodine. Oop. Hmm?
Or people that
No, no,